Hey there, this is Dr. Izra with Integrative Kidney Solution. I've been a practicing nephrologist for more than 15 years. And this video is a first video in a series of videos that is intended mainly for primary care providers to talk about specific topics in nephrology so that we can help improving patient quality of care and outcome. These videos are low budget, made by me, so there's no big productions, there's no Z-Dog MD type of videos. All I'm asking for is to share these videos and help us spread these information so that we can improve patient care. I'm not asking anything from you in return about that. So, and there's no catch. And in this first video, I'm going to be talking to you about the myth of metformin use in kidney disease patients. So for many years, many clinicians have been avoiding the use of metformin in kidney patients, and those specifically with diabetes, obviously. And this is fueled by the FDA warning about the use of metformin in these patients. So if you look at the actual reason, a lot of doctors think that metformin can cause acute kidney failure, acute kidney injury. But the actual reason why metformin was literally banned from the use of kidney patients and who have diabetes is because of lactic acidosis, not because it caused kidney injury or kidney failure. Interestingly, if you look at those early reports, many of those patients have septic shock. They had a reason to have lactic acidosis to start with, and also the septic shock also caused worsening of their kidney function. So what metformin did in this case is augmenting lactic acidosis in those patients who are really getting sick from another reason, like septic shock or other type of shocks. So how does metformin cause lactic acidosis? So if you remember the mechanism of action of metformin from your pharmacology classes, it simply works by inhibiting glucose production by the liver. And if you remember also the Cori cycle from physiology, you remember that our muscle generate lactate from anaerobic glucolysis, which is converted back to glucose in the liver, and that's the main way that our body works to prevent lactic acidosis, basically. So what metformin does, it inhibits this enzyme called pyruvate carboxylase, which increase pyruvate conversion into lactate. So metformin also inhibits the electron transport chain necessary for aerobic glycolysis, leading to increased level of NADH level, which inhibit glycolysis via the Krebs cycle, the famous Krebs cycle. And therefore, it increases the flow of the metabolism of glucose into lactate. So with kidney failure, so metformin is actually 100% excreted by the kidneys. So with kidney failure, metformin accumulates, which may lead to increased inhibition of the aerobic glycolysis. But what is happening here is not that metformin is causing kidney failure. So many physicians think that metformin causes kidney failure, which causes lactic acidosis. But in reality, what is reported in the literature is that patients develop septic shock, they develop kidney failure and lactic acidosis. They accumulate metformin, which further augment the lactic acidosis. So in another word, a septic shock in the presence of metformin is worse than a septic shock without it. So should you use metformin in kidney disease patient and CKD patient? Well, a study recently looked at that specifically. More than 75,000 patients with type 2 diabetes were followed over a 13-year period. They had 2,335 hospitalizations. Only 29 of those have acidosis as the primary diagnosis code. The study concluded that metformin, actually compared to other diabetic treatment alternatives, was not significantly associated with acidosis, especially in patients with GFR of 30 to 60 ml per minute. So, however, there was a correlation between lower GFR use and the risk of acidosis. And that actually is true whether you have metformin or not. And that's what the study showed, that it's regardless of metformin use, you have a higher risk of acidosis in a patient with lower GFR. So rather than entirely excluding metformin from the use of your diabetic patient with kidney disease, the benefit is substantial and warrants the use of it. So the bottom line, metformin, number one, metformin risk is by causing lactic acidosis and not by worsening kidney function in patients with advanced CKD, especially those with GFR less than 30 ml per minute. To continue to prescribe metformin for diabetic patients with GFR more than 30, because it's safer, and actually we know more about it than any other of those newer diabetic medication that we don't have long-term studies on their safety for kidney patients. So another group of patients I would like you to be worried about the use of metformin for them. These are the patients who have renovascular disease, such as renal artery stenosis. And those patients have fixed renal flow. So, you know, the renal hemodynamics does not change because that stenosis that they have, and their renal flow is really dependent on their volume. So you can see that they, with minor changes in volume, they end up with large fluctuation in their kidney function. And those are the one that you see if you look at historically on their creatinine. You can see that their creatinine fluctuate widely. And if they're fluctuating into stage 4, those patients, particularly, you should avoid using metformin for them. And finally, if your patient have acute kidney injury, please hold metformin for them. Now, the next and final question is, should you hold metformin before contrast dye, iodine contrast dye? And certainly, you know, the radiologists, you know, they will not use metformin. So this question is very complex, considering the controversy right now whether contrast nephropathy really exists. If you read the recent cardiology literature. So metformin is not going to increase the risk of contrast nephropathy per se. What you're trying to accomplish is minimizing the risk of lactic acidosis in those patients who develop contrast nephropathy. So if you think about it this way, holding metformin on the day of the procedure does not accomplish anything. If anything, you should hold metformin for actually the week after the procedure. And if the patient does not develop contrast nephropathy, then you can resume metformin. So basically, you know, if we know that contrast nephropathy risk increase at its peak between day 3 to 5 after receiving contrast. So if by day 5 the patient has stable renal function, you can resume metformin, obviously with monitoring the patient's kidney glucose level. So I hope this video was helpful to you, and if you like it, please share it and subscribe to our channel. If you have any specific questions about specific topic that you want us to explore further in future videos, please post them in the comments. These videos are not meant to really talk about specific diseases, disease processes, or treatment, but mainly few topics in these short videos. Thank you. Please follow us on www.inkidney.com.